everyone. We are going to start our session today. Thank you for joining, everybody. Today, we have a speaker, Fivzia Herekar from Indus Hospital, Karachi, Pakistan. And she's going to introduce herself, and then she will present, and then I can afterward introduce the panel, and so that you can gear your questions towards their particular expertise. So with that, I will ask Fivzia, please go ahead and start introducing yourself and then your presentation.
Yeah. Assalamualaikum. My name is Dr. Fivzia Herekar, and I'm an infectious disease specialist at the Indus Hospital, especially the Parangi campus at Karachi. So, and in the current pandemic of COVID, I am the clinical lead for the inpatient admissions at the hospital. I'll just be going over what we've been doing at the Indus Hospital and how we've prepared for this and dealing with this epidemic. So just to give you a perspective, almost touching the 2 million bar of patients who have been confirmed with COVID, and the death globally is almost 120,000. This is, as of yesterday, the national statistics of COVID cases in Pakistan, around 5,837. With in the last 1 week, the death rate has gone really very quickly up. Punjab is leading in the cases, with Sindh following very quickly. Okay, so to give you a history of how it happened in Pakistan, the first case was recorded on 26th of Feb. And so the federal government took a good step in controlling the initial surge of patients by controlling all people coming in from China, keeping a screening which was very appropriate. However, what they did not, I feel, do was keep a lookout for all the other hotspots. And so other travelers who came in were not screened as appropriately as the numbers and hotspots were going up in the global pandemic. The first cluster of patients who came out to be positive were basically recorded in the Zairine, who came in from Iran, and that was a big cluster that came in. The problem with this was that I think Iran was late in detecting their own COVID cases, and hence a lot of them actually had come in and disseminated in the community. And when the numbers went in, we did sort of quarantine them, but the initial quarantine was not up to the mark, and we sort of created more cases. So if you see the chart, initially there was the green ones marked the Zairine. So you would see that the number of Zairine were more than what the normal population or community people were affected by. But slowly and gradually, it's been all over. So now you see that community spread is there, and hence from 16th of March, the Sindh government has declared a lockdown, and followed by the federal government for the rest of the areas as well. How has Indus responded to this? From the very start, the Sindh government had involved the leadership of Indus Hospital along with Afan as well. And so we've had a very strong liaison, and they've wanted Indus to lead in COVID admission, screening and testing. We very rapidly, we had around a 2 weeks break when Afan was taking most of the cases, and we did a lot of preparation time we had, and we really went through that. We revised the scope of services, closed the OPDs, managed the crowd. Community and staff screening was set up at every entry point of the hospital. The ER was restructured when we experienced a huge number of patients coming in. We quickly restructured the ER to dedicate a space which was for respiratory ER, so that our healthcare workers were appropriately dressed and would face the suspected cases appropriately. One area of the hospital was identified and was converted into COVID inpatient unit. All sorts of guidelines in patient flow and SOPs were made. So Indus has a network, and so these was all shared over different network hospitals all over Pakistan. Uh, Training of doctors were done on an urgent basis on donning and doffing and other infection control practices. In-house lab testing facility was very rapidly taken on board, and after validation we started doing testing at a high rate. Our testing time, turnaround time, has been around 6 hours, which is a huge accomplishment for us, because it's easier for us to document whether COVID negative, and then other hospitals would be more ready to take the patients rather than someone who may have a positive, because till now other hospitals are not accepting patients just because they may have COVID. Very rapidly, we understood that PPE, not only in Pakistan but globally, is a problem, and the misuse of it would bring us down with an acute shortage. So a whole control and command system was created where PPEs were appropriately and very strictly monitored so that we do not run out of it. Uniformity of data was absolutely necessary because this was data which need to be shared nationally. Medicine availability, pharmacy was taken on board. Envisioning what would happen when community spread occurred, we did prepare for operating and labor room restructuring to receive all patients. So the panic, unfortunately, the panic has been there for quite some time, but people have not taken steps to prepare their hospitals to cater for this, to protect their healthcare workers or take in patients who may not be COVID positive. So, because of which the patients have suffered who were COVID negative and had other problems, they were also turned away and turned to the doors of hospitals which were accepting COVID patients. Indus has always had the vision of not turning away anyone they can help. So we also started our teleclinics very soon, and we have another part of our Indus team, which is the Global Health Directorate. We took them on board. So what they do is they screen and test all the patients who come out positive. They go to their families and they test that cluster of patients and are helping us do that, and also help us in keeping a lookout on patients we send home on home isolation or quarantine, because that is very necessary. The structure of the population we are catering of the for is extremely poor. So it's very important to capture those patients who may go back and mingle in the community. Okay, so these are some of the snapshots of how every entry point is for patients, attendants, and healthcare workers are screened every day before they come into the hospital. This is the embedded facility with 15 ventilators, and most of them are Hamilton. I know they're recommended. This is the local, the Indus Health Network guidelines for management, and I think a lot of these SOPs and guidelines have been made by Dr. Samreen Sarfraz with liaison with the infection control. So, a really very well done job by her. For burial guidelines, this is a very sensitive issue, and we do feel now also that the bodies of the deceased are not appropriately taken care of, but we've made the burial guidelines and we are still trying to improve and improvise on. Another thing which we are very proud of is the screening app, which has now been shared at different areas and different countries, in fact, and it's some questions of it are very indigenous to the Pakistan cohort, and this is what gets shared with us. This is just the Kurangi campus, and just to give you, as I shared previously as well, we have a lot of other network areas, and we cover a lot of areas of Sindh like Nawab Shah, Dadu, Sakhar. So, and our lab is testing for almost all of these areas, and we get a report of how many are tested, how many get positive. This is a report which is shared on a daily basis with us. So now, what we've been doing and treating, and what we have been using as treatment modalities at Indus. We've been, with the literature coming in, it has been a very fluid protocol, and it has kept on changing very rapidly with newer evidence that has been coming in. And we've been trying to do whatever we can to save the lives, because, we have had now in this week, more numbers of critical patients are coming in, needing vent, needing high flow oxygen. So we are trying to use whatever has shown any benefit by the evidence that is available. So for HCQ, we use it in almost all the patients who have moderate, severe, critical condition. We've been using tocilizumab for our severe and critical patients. Very recently, only last week, we started using methylprednisolone, and very, I mean, like, even now, I think it has been remarkable and beautiful, but I think the data is like still premature to be shared. uh, However, we've seen really amazing results, and we've averted people from going on the vent. And we've also used methylprednisolone with tocilizumab. The background bone is always HCQ. We're now also moving towards anticoagulation, and it's, again, we keep on reviewing the literature. If it seems to be, beneficial, we use it. When the data says, it's not coming out, and then we have our own experiences with it also. Talking about critical management, this has been a problem with us. Managing ventilation, as I shared earlier also, we have very limited resources and expertise, and so we've been training and ourselves trying to learn what is. Our anesthesia team has been on the front line helping us with the ventilators and sedation and all that. But these are the sedatives that are available for us and what we've been using. Mainly, we've been using the pressure support ventilation mode, and what we've now started doing is wakeful proning, and I think that has also shown us very amazing results. But it's a difficult thing to do when people are not cooperating with us. We are not sedating the patients for proning. We are just, whoever is compliant and yeah, is able to understand, we do it in those. And seriously, with the methylpred combination and the proning, I think we've really had some successes. We do not advocate any procedure which causes aerosolization, which may be nebulization or non-invasive ventilation or even high flow oxygen. We rather use the rebreather mask in the unit. We've been using the non-invasive in the emergency department, but because the unit does not have a proper negative pressure facility, so we don't want to expose our healthcare workers. So I just wanted to share tocilizumab experience because from the previous lectures that I heard, it's not being used very freely in America, I guess. Now maybe they've started using, but by the lectures I heard. So I just thought I'd share our experience. We use an 8 mg per kg single dose, which would be maximum up to 800. We select our patients on the basis of these markers, an PaF5-2 ratio which is less than 150, bilateral infiltrates covering more than 50% of the lung, high CRP, high ferritin LDH D-dimer, and procalcitonin, which should be negative. So up till now, for the tocilizumab alone with HCQ therapy, we've had 8 patients in whom we've used this. All were ventilated, and X-ray remarkably improved within 24 to 48 hours. There was a rapid decline of CRP from 247 to 38, and then now it's like in one of the patients it's 10 and 8. Hypoxemia improved. 6 continue to be on vent because they have other issues. I mean, we've still not been able to ventilate them properly, and I think it will just take time. We've learned that it takes time, even if the X-ray gets better. 2 unfortunately expired. This is the first tocilizumab, and it was just a wow factor that we saw within 24 to 48 hours that the X-ray absolutely cleared off. So the next thing that we took on board was methylprednisolone alone for those who were moderately ill, and for those who did not improve. In 24 to 48 hours after methylpred, we also gave them tocilizumab. This was a self-created criteria in which we used methylpred. And so out of the 5 critical patients, 3 actually went down from a 15-liter oxygen requirement to 2 to 3 liters in 48 hours. 2 had to be ventilated, and 2, it also depends on what stage of the disease they come. So most of the patients who came within 5 days of their disease and were very sick and critical with these criteria fulfilling, they responded really well. 2 moderately severe patients with methylpred alone have become off oxygen in 38 to 72 hours, and all 5 patients averted from ventilation by early intervention. So this was an X-ray of a patient. He's still on the vent, but after methylpred and tocilizumab, you can see a remarkable improvement in the X-ray. What I've learned over this brief time, over my 40 patients, is that patients with significant hypoxia, but they don't have mental status changes. They are talking, two of them actually wrote their will before they were intubated. They're very difficult to state with multiple things that we are using. We have a difficult time with that, but that's why we need to use the muscle paralysis. There have been patients who have had hypertensive urgency. I mean, is it because of drug interactions, or sometimes when we are using Presidex, which is wakeful sedation? But we've had a hard time controlling blood pressures, and with the fear of using ACE inhibitors, it's been a difficult time controlling the blood pressures. Hyperkalemia and metabolic acidosis is something which is ununderstandable in patients who are making a good urine output. Their lactic acid is not very high, and their creatinine is not rising. But this is something we've been noticing. Hypoxemia, despite improving X-ray, and respiratory acidosis in those in whom hypoxemia is not an issue. Thank you.
Thank you, Fivzia. Very comprehensive and great presentation, particularly giving us a window into how the things are in Pakistan, particularly in Karachi. There are other attendees and panelists. We will get their perspective as well. So let me introduce our panelists. And as I go one by one, I will ask them to please introduce themselves, and then any question or comment. So Dr. Amir Ghafoor Khan has joined us for the first time from Peshawar. Professor Amir Ghafoor, please go ahead. You are unmuted.
Thank you. It's a pleasure. We've been trying to join, but usually at this time, because where I work, Lady Reading, we start our meetings and this COVID business. We are a very large tertiary care hospital, as your audience from Pakistan would know. We've received cases which are really, because we cater for a very large area, KP, along with Afghanistan. We've not had any we've had Afghan nationals. In fact, the person who has recovered completely was a gentleman, a 47-year-old from northern Pakistan, who had gone to UK and come back from UK. And we were able to excubate him after being on vent for, I think, 12 days. And he did well. From what I gather from my intensive care team, we had a link with China yesterday, and methylprednisolone, for some reason.
We have been discussing with this, and let's see what other panelists say about this or other issues. Asma Chima, you're unmuted, and go ahead and introduce yourself and comment. Asma, you have to unmute yourself as well.
Assalamu alaikum, everyone. Assalamu alaikum, everyone. My name is Asma Chima. Dr. Fivzia Herekar, thank you. Very nice presentation. And thank you for sharing with us. And you mentioned about there's a concern with ventilation management, and most of them are not trained about it. So I just want to share with you, there's a one course available free. Of course, Apna Merit is going to start next week, vent management, and you will learn, and your colleagues can learn as well. But for that time, you can go to the edX. Harvard University is offering free course for mechanical ventilation for COVID-19 patients. It's a very comprehensive course, and if you can share with your colleagues, it will help.
Yeah, definitely. Thank you.
Thank you.
Next is Kaleem Ahmed. Kaleem, please introduce yourself and then comment or question.
Assalamu alaikum. Kaleem Ahmed, Pulmonary Critical Care, Sleep Medicine. So regarding using methylprednisolone, the data from the China and also from the New England Journal initial publication was discouraging the use of methylprednisolone because of the increase and prolonged viral shedding. Now, that is more of a infection control and spreading strategy. But when it's come to the critical care management, the majority of the expert has seen when the cytokine storm happened, especially in two kind of scenario. One is an initial shock when, despite of using vasopressors, including norepinephrine, vasopressin, and still patient arterial blood pressure is not stabilizing, using hydrocortisone about 200 milligram over 24 hour, either continuous or intermittent dose. That one scenario. And the second is with the patient who are already on the vent in ARDS with all the ARDS kind of picture and is still having problem in terms of oxygenation. Then during that time, low dose Solimedrol have been tried and it has shown improvement before trying any other modalities for increasing the oxygenation. The same kind of thing, I think the randomized control trial is going on also at Mount Sinai. Recently, I think 2 days back, there was ERS and ATS international webinar, and they were sharing this experience. Data is still not out, but these are the two scenarios where they have shown improvement, and as Fivzia has shown some improvement in the radiographic changes. So I think that the data is there, if not 100%, but compatible to use this modality. One thing which I will ask Fivzia about, I saw from your presentation, there was about 14 ventilated patient, 6 expired. So any patient who develop severe shock or severe ARDS, you guys able to wean them off or not yet?
So we haven't been able to wean anyone off yet. So people have been in shock with NORAD support, but it hasn't been like, on double support or something. We've almost had we've been able to wean off the support actually. The ARDS again is not behaving like ARDS completely. Like I said, the oxygenation has not been the problem in most of them. In 2 of them it has been, and then 1 of them developed back. So one of our first ventilated patient is now on 20th day of ventilation, and yesterday only, we've had really high hopes of him. He's woken up and he has a 50% FiO2 now. Now we are trying to wean him off. So that's one hope that we have. All the patients who have expired were not on ventilation. 2 of these were non-ventilated patients who expired.
Okay,
thank you.
Thank you. Let me invite Mohammed Salim. I'm unmuting you. You also have a question, and please introduce yourself and then ask your question or comment.
Assalamu alaikum, everybody. Thank you very much. It is a very nice presentation, and it is a very good forum for our learning at this critical time, because we are sitting in very remote and peripheral areas, and it is a very good forum. My question is that during routine journal ward rounds in our setting, because there is asymptomatic viral shedding, and can we do this ward round with full PPEs, or what protective measures we should take? Thank you.
This is Kaleem. I can tell you what we are doing, and it's all on the basis of the guideline, which has shown protection from the spreading the viruses to the healthcare provider. So if somebody is rounding the patient and you are concerned or you're not sure about the COVID status, use the surgical mask all the time. That is what we are doing in our institution. Everybody, every healthcare provider, they're using the surgical mask. And then definitely hand washing, fomite careful with that. And then we're also using the disposable eye shield, not the full eye shield which we use for the COVID patient, but there's some protection in front of our own glasses of the eye to prevent any kind of droplet. So this is what we are doing.
Thank you.
Thank you, Kaleem, for answering that. Let me move on with our panelist, Dr. Mariam Moten. You're next. Please introduce yourself and question and comment.
Assalamu alaikum. This is Mariam Moten. I'm a cardiologist in Loma Linda, California. We are practicing a lot of social distancing, and as far as full PPE on the wards, this is not what we are following. We are just doing the face mask and good hand hygiene. That's what we are recommending to everybody. Thank you.
So attendees and panelists, anybody who has any question about cardiology or cardiology illnesses, as we know there are many in COVID patients, please, this is your chance to ask Dr. Moten, who is a cardiologist in the panel. Next is Mehreen Arshad. You are unmuted. Please go ahead and introduce yourself.
Assalamu alaikum. I'm Mehreen Arshad. I am a pediatric infectious disease expert at Lurie Children's Hospital at Northwestern University in Chicago. And so we have, so we're a freestanding children's hospital. So luckily we have not been inundated with COVID-19 patients the way that our adult counterpart hospital is. However, we are seeing more and more young adults. So we increased our age, of admission to 25 years. So we are seeing older teenagers and young adults who are, COVID positive, and some of which have underlying diseases, also getting admitted and requiring ventilator, requiring ICU care. So again, luckily, it's not as bad as in pediatrics, but I think, given the those patients that have some underlying diseases, we are certainly seeing infections and sometimes severe infections in them as well.
Thank you, Mehreen. Next, I would like to...
Can I
Amir,
say something?
Go ahead, Amir.
This is in to what Salim was saying. Obviously, you see, Pakistan being a resource restrained country, this business of PPE is causing us a lot of heartache, because you see, generally the young doctors are, of the opinion that these things should be worn for any patient, or most patients. Now the problem is, you see, we've seen them being worn, and then people walking out and taking pictures in it, and which you can understand the enthusiasm to, but you see, I think this is something which is worrying. I think, as Fiza said, that unless the attendants who deal, or the consultants who deal with the patient who are COVID positive for sure, maybe that's how it should be restricted, because otherwise it would become impossible. I'm sure all of us have been following it. Even in US and UK, they are struggling to have PPEs for everybody, although you have a much larger caseload. So I think this advice maybe from your forum, maybe in writing, that surgical mask and just general, common sense precaution for any infection which a good doctor should be doing should suffice. I mean, I hope faith is on our side, but I think it would be next to impossible to be able to, have PPEs for almost everybody who who's suspected or people think might have.
Right. It has to be graduated from, asymptomatic patient, suspected COVID patient, obviously come in the same category under investigation as COVID, and then, of course, intensive care. Let me go to Dr. Kabani. Please introduce yourself and question and comment.
Sure. This is Dr. Kabani. I'm a pulmonary critical care physician in Houston. And first of all, Fivzia, that was an excellent presentation, and you gave us a very good insight into one aspect of care in Pakistan. Thank you for that. What I wanted to ask a couple, not really ask a question, but make a comment on a couple of things in your presentation. One was that you had mentioned the use of anticoagulants. And that has been an area of controversy also in the US. But I think it was on April 6th that they came out, Tulane came out with their data, autopsy data, where they showed that there was a lot of microthrombi as well as major PE and DVT, and that was found at autopsies. Which I have yet to compare it with the China study. I think they found something similar to it, and that they started using prophylactic. But as far as I am aware, and Kaleem, you can chime in here if you like, the society guidelines have not changed. They are still talking about only prophylactic. However, in the clinical practice, many hospitals are using full dose anticoagulation. So I was just curious to see in what setting you're using it and what your criteria are. That was number one. And number two, and this is a minor point, I was just wondering if your ventilators mode you meant was a pressure control mode rather than PSV. But that's not something important at this point. We can talk about it in the ventilator course. My final comment was that it looks like in this hospital, as well as I'm in touch with Aga Khan Hospital also, they have, I'm in touch with the alumni at AKU, so I'm getting some insight into that outside of this conference, that they're sort of taking the lead in Sindh. However, is this model being replicated in the rest of the country in some form? Does Aga Khan and Indus have some sort of an influence on what is happening in the rest of the country?
So I'll take your comments one by one. The first about anticoagulation. Well, following the critical care bundles, we are already giving a prophylactic anticoagulation as it is.
Sure.
But very recently that we've seen patients who have had D-dimers which were more than 1,000, and who were hypoxic. We've started using therapeutic anticoagulation in them. I would leave the ventilation part because our counterparts, the anesthesia team does most of the ventilation part.
Sure.
The third point was about Khan and Indus leading. Well, by somehow being put in this situation and being very, with the vision of helping everyone out, every patient that needs help, these two institutes have prepared themselves to be ready for everything. Unfortunately, the panic that has been created and the way people have not been prepared, other hospitals, private institutes, and even government hospitals have had more healthcare workers being affected by COVID because they weren't prepared with it. They were not screening. They actually took on the patients, the regular patients, without screening them on, and they got infected. Alhamdulillah, at Indus, we have not had any patient-related infection. There have been employees who've had community transmitted infection, around 5 or 6, but not per se that. So that's what I'm saying, that then the willingness of taking on board COVID patients has not been there for, we're there. I mean, even the Infectious Disease Society is ready to train and help people. The AKUH alumni, along with our ID people, have formulated national guidelines, but it has to come from the leadership of each institute, that they need to understand the need of time. Let's be the COVID patients. Patients who don't have COVID are being neglected just because of that.
Can I add to that? I'm Dr. Sabreen Safraz, working at the same institute as Dr. Fivzia. Today we are planning a nationwide webinar, the first national webinar to be conducted by the Indus Hospital. We have got participants from at least 25 centers across major admitting centers across the country. And we have done a survey and a poll of results of what's happening around the country. So just a brief snapshot of things elsewhere. Ethical guidelines are not in place in many places. As Dr. Fivzia said, the process of screening is not in place in many places across the country. The thing that healthcare workers are getting infected, this has been reported throughout the country, and that is because of not being careful where and how to use them, not being trained enough, and the reluctance to admit patients with COVID-19 is also present. Especially, I can say for the city of Karachi, there are only 6 major centers in the city who are admitting moderate to severe COVID cases, whereas we are seeing a surge in cases. There are many private hospitals which have the capability of admitting, and they have ventilators, they have the manpower, but they are not our motto. We cannot refuse, and we do not refuse patients. So we have been thrust into the limelight, and basically because we are accepting. Similar is the case with SIUT, if you know, Sindh Institute of Urology and Transplant. They're also accepting patients of COVID-19, moderate, severe, critical patients. But sadly, this is not what is happening across the city.
Thank you.
Can I say something? Obviously, you see, the question of admitting an official setup has to be taken up with at a government level, and I think Bari Sahab is almost on all the government hospitals are admitting. We've not had to, have them admitted in private hospitals. So I would suggest that, if not, I'm sure you could, or if you want, I could speak to Bari Sahab, and this can be sorted out. This should not be a big...
No, it's not like that. It's like, see, there has to be a will from the hospitals as well. There is a pressure from the government, but and there are government hospitals in Karachi like Civil and JPMC who are one of the admitting facilities. But the burden of disease is more severe, and the requirement for oxygenation and ventilation is more as compared to the rest of the country. So we need to scale up on the ventilated beds and the critical care capacities in the city pretty soon. And this is not being translated as rapidly as is needed. That's what I wanted to say. And it's true, Bari Sahab is there on all the committees, and that's why there are things which are moving there, but things need to be moved faster. That's there.
Gee, thank you for that. Let me take some questions from the audience. Professor Arif Herekar has raised the hand. I would unmute you, sir. Please introduce yourself and ask your question.
Do you hear me?
Gigi, sure. Go ahead.
Okay. It was a very good session. I was it's pretty impressive. Dr. Fivzia has already elaborated on everything that we need to know. My simple question is, since I'm a neurologist and professor of neurology, and I would like to get back to my clinics, the first question was, have you found any difference between the medical professionals who are using the proper PPEs and those who are just simply using the mask and the gloves? I mean, this is the question. The other thing is that how soon do we get back to our patients? This is very important for people who have been exposed. Of course, I've not been exposed because I have isolated myself, I think, for very good reasons. And especially with the age coming on, and I'm a retired professor. So my question is that if I were to go back to my practice, it's a full day practice, and 38 years now. What do we do if we go back to our practice? The simple masks and the gloves, are they good enough? And distancing, of course, is the primary thing. The scary part is that although distancing has been promoted and elaborated on all medias, but this has still been a problem. So awareness in distancing should continue to be enhanced so that people understand this. This is very important. The other thing is that things are opening up probably today, even though they are partially opening up, but with the exponential increase in cases, this is a wee bit scary. But so I'm going to, because of time constraints, I'm just going to shorten my thing. My question is that was there a difference between the medical professionals affected who are using a full PPE and those with simple mask and gloves? And what do I do to continue my practice?
Shahid,
you want to go ahead? I just wanted to welcome Dr. Herekar. Dr. Herekar, I'm also a neurologist, Shahid Rafiq here in Frederick, Maryland, and Danish Bhatti also here. Our co-chair is a neurologist. So basically, just before Kaleem adds, I think the general guidelines come from the state and the government here. For example, Maryland State, when they decide that now is the time that we are opening up and social distancing is loosened, then will be the time to, at this point, we are not seeing zero patient in our office, even not doing even procedure EEGs or EMGs. But once they open up, my thing is that even patients themselves, they will not come like before. So the numbers will be less. And I would be worried about, I can wear the mask and gloves, but I would also be worried about them sitting in the waiting room close together. So we have to innovate, each one of us, whether we are neurologist or cardiologist and other offices or primary care, to come up with probably we'll have to give them masks. Anybody who comes in our office while they're sitting in the waiting room, they should have at least a mask on their face. So things like that. But go ahead, Kaleem. Fivzia, then I'll come to you. Kaleem was going to say something about it.
No, I think, Shahid, you have summarized this very well. This is what exactly I wanted to say. So nothing to add.
So Fivzia, you wanted to say something?
Yeah, I just wanted to say that nothing comes from the state right now. As mentioned, people are not practicing social distancing. Unfortunately, what we are seeing are the general practitioners or the patients who are working as independent clinics being affected more rather than those who are working in tertiary care hospitals, where still people are aware of screening protocols and PPEs. Now is not the time to restart general practice if you are not going to take all the proper precautions, because the numbers are climbing. This is the week last was the week that we entered into the critical phase. And with the type of mingling of people and no social distancing, the numbers are just going high. So we have a doctor on vent right now. We had a doctor who had expired, and both of them were doing their clinics till the 1 week prior to getting ill, and even with symptoms. So I think if you have a very small unit, have a well-ventilated area, you can control the crowd, you have an appointment system in which you can screen properly, maybe with proper PPEs you can start keeping all the cons in mind. But we are now having asymptomatic patients who have been admitted with some other problem and getting diagnosed at COVID as well.
Right. I see Mehreen wanted to add something. Mehreen, go ahead.
I just wanted to add to the question about, what is considered proper PPE. So I feel like different institutions are doing different things depending on, based on what their threshold for risk is. So in our adult hospital and as well as the pediatrics, we're doing universal masking. So everybody who comes into the hospital, whether it's a patient or an attendant or a physician or, any healthcare worker, everybody gets screened for, fever, and then everybody gets a procedural mask. Okay, so that's one thing that we're doing. The other thing that we're doing, so again, we have to remember that I think we still, the vast majority of spread of this virus is still by contact and droplet. I know there's some data out there and maybe some controversy around that about aerosolization and airborne. precautions that might need to be taken. But at the moment, most of the airborne precautions that we're taking are in patients who are undergoing procedures that are at high risk for aerosolization of patient secretions, which include, I think stuff that's been mentioned before, like high flow nasal cannula, the time that, time when patients are being intubated, or if there's, doing a bronchial alveolar lavage. Outside of that, we are at our hospital are seeing patients with surgical masks and proper hand washing, gloves if needed, but we are not wearing N95s for every patient. And then in terms of our experience in our hospital with those all those precautions, we have very little healthcare healthcare worker infections at the moment. Before we did universal healthcare or universal masking, it was interesting because in our pediatric, in our children's hospital, we had very few inpatient COVID-19 patients, but we had, about 30. So we had right in the beginning, we had about 3 or 4 patients admitted in the hospital with COVID-19, and 30 of our healthcare workers were positive for COVID-19. So 10 times the number of, and none of those healthcare workers had come into contact with patients. But what we figured out was that that the healthcare workers that were sort of spreading it out within themselves, so they were basically getting infected through the community. And then, because everybody works together in the hospital, they were not being careful. So my point being that, you can when you go to work in a hospital or in a clinic, you can not only get the viral infection from your patients, but also from other healthcare workers. So basically maintaining, good surgical masks or procedural masks and hand hygiene and social distancing at all times is absolutely crucial.
Okay, great. I see Dr. Motin, you wanted to add something or new?
I just wanted to reemphasize the same thing. Social distancing was considered more important than anything else in our institution. We encourage face mask, and compared to the other county which was next to us, the LA County, there the population is much higher, and they did not strictly enforce face mask and social distancing as much as Loma Linda. So their case fatality rate is much higher than ours. So it tells us the social distance does help. In addition, most of our patients are now telemedicine. We do telephone visits, or we do video conferencing with the patient right now.
So Dr. Motin, while you're on, I wanted our Zahur Khan has asked a question specifically to you, saying, wondered if you may comment on left ventricular function in COVID patients, as the data may have beefed up till this point.
Last I checked was as late as early this afternoon, and the LV dysfunction is present in some individual when they come in with infection with COVID-19. Just like in any viral infection, it's a hit and miss. As far as the recovery of the left ventricular systolic function is concerned, it recovers in some individuals, but not in most of them, but it's too early to say how many patients will recover. In addition to LV dysfunction, there have been cases of RV dysfunction as well, with normal LA pressures, and the IVC is also not collapsing. The inferior vena cava is not collapsing, indicating that the patient may have some increase in RA pressure. But majority of those patients, when they go to the ICU, they get dehydrated and the IVC seems to collapse completely. So we know there is some hemodynamic changes that are happening in the patient, but LV dysfunction does happen in patient with viral infection.
Mariam, could I ask you something while you're there?
Yes, go ahead.
Mariam, I just wanted to ask you about usage of cardiac cath lab. So obviously, PCIs and these things have to be done in patients who are not COVID. COVID, I understand we could do the PPEs and things, but we were thinking of using our elective lab. So we've got a 4-story building on which the cath lab is at the top floor, but the first floor was being used for, or is trying to be used for COVID patients for isolation. So is there a worry about the central duct system causing difficulties?
Our cath labs are completely isolated. They do have some negative pressure rooms, and that's what we are using at this time. I'm not sure if the conduction system through the ventilation, through the air conditioning would carry the viruses. It is assumed that it does carry the virus, and therefore the viruses tend to go on the higher level. So using a higher level may be a problem. We are postponing all elective cases. No elective cases are being done. Almost like 70% of the cases are being canceled and have been put away, especially those that are getting pre-TAVR screening, patients that are going for mitral valve replacement that need a pre-cath before the mitral valve replacement. Those patients are being put off, but people coming with a STEMI and STEMI with a markedly elevated troponin, those patients are being taken into the cath lab. Those with borderline troponin elevation, patients with what we call as troponemia or type 2 myocardial infarctions, those are not going into the cath lab. But as far as your question about getting the, using the air conditioning system, having the same system upstairs and downstairs, that's generally not advisable.
Okay, thank you.
All right, so I'll go to one of our attendee, Khalil Mobeen. Khalil, you go ahead, please, and introduce yourself.
I'm Dr. Khalil Mobeen from Karachi. Can you hear me?
Jidi.
From Karachi. My question regarding data presentation from Indus Hospital is that can the presenter tell what is the proportion of the expired patient from ventilator who are old age and who are having different other comorbidities like hypertension, diabetes, cancer, something like that? And second question is that, can anyone tell me what is the definition of an epidemic or pandemic? Because as far as I know, when a disease exceeds, the incidence of a disease exceeds 1% of the population, it is said to be pandemic or epidemic. But the position at the moment is that COVID cases are not exceeding 0.05 or 0.025 like that of the total population. So can we tell that epidemic or pandemic? Thank you.
So I'll answer the first part of the question. Off my mind, out of the 14 ventilated patients, around 7 have died. So it's been a mortality of around 50% already. All were critically ill. Almost all were above 60 years, and comorbidities, not all of them had comorbidities. But as Dr. Moten was talking, we had quite a number of them who had troponitis and very high levels. So some of them were actually treated as N-stem elevation, N-STEMI. Yeah.
Oh, thank you. And second part of the question?
About epidemic and pandemic?
Yes.
That's an exam you're taking. I don't remember the definition about it, but it's about the pandemic is something which the WHO took a long time to declare it as a pandemic. So I mean, yeah, I cannot quote off my mind the definition.
Okay. It means there is no clear-cut figure for the disease to be diagnosed as a pandemic or epidemic. It depends on the scenario.
Yeah, maybe somebody else can also shine.
Sure.
I think the reason that this is called a pandemic is one, so the definition is not set in stone, for one. WHO, has also admitted that. Part of the reason why this particular is, spread is pandemic is because by definition, pandemic is across a large area. And so this is basically an international spread of the virus, and the rate at which it's spread is extremely, it's extremely fast, and that is something that we have not really seen in the recent past. And so that's why WHO has deemed this a pandemic.
Okay.
This is Kaleem. Just to add that, I think it is not an static definition. It is on the basis of statistical modeling, on the basis of the distance from the area of the start of the disease process to the different part of the world. And then those modeling make it, WHO to decide whether this is going to be, at what stage is going to be a pandemic, because the number of the population presumed to be affected if things are going to continue in that direction. So it's not something which is static, it's a dynamic process on the statistical modeling.
Thank you, Kaleem.
Okay.
I
Thank you
will
very much.
ask one of the attendees, Nigat Ahmed, has a question. I will allow Nigat to talk, you to talk. So can you unmute and talk? Nigat Ahmed? Okay. Because the question was not totally clear. I'll try one more time. Nigat, you have to unmute yourself as well.
जी आपको मेरी आवाज आ रही है
जी बिल्कुल आ रही है आप सवाल कीजिए
I have a question mashallah I find this extremely useful because most of the people over here are Pakistani origin, they understand our limitations and everything, and being a rheumatologist hamari disease can present in any way like COVID also. So one of my questions is that most of my patients, when we do interview before we do call them into the hospital, we are on telemedicine. My question is this, that when we suspect that this patient has fever and blah 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 and should test, they will never test. They refuse to test because the police comes in and takes them away, and you all know what's this is why it is being done, because I think CDC China said that they had failed this home isolation thing, and that's why Wuhan was what Wuhan was, because people did not know how to isolate themselves at home. I think we have made a home care plan on the Arthritis Care Foundation for treating, for guiding people on who are mild and who are moderate, who are not hypoxic, to stay at home. And we can even do, digital vigilance or digital fencing. So people have, most of the people have stopped testing. Yesterday, I recommended somebody had come from a village, and I said that that patient needs to be tested because of certain reason. And the family said no, because then we'll just home quarantine that person for 7 days. But with the testing, this is like mind-boggling. So as Apna is a great forum, and I think, what do you think about this? Taking away people from home as soon as the test arrives, and so people are not getting tested. So I want your opinion on this. My opinion is that patients with mild and moderate symptoms who do not need to come to the hospital can be managed by their healthcare teams. We can train people. There are so many volunteer doctors who would love to get trained and guide them how to do it. Itne doctors hain yahan pe jo is waqt clinics nahi kar rahe, kuch nahi kar rahe. We can develop a team of home care and we can guide them. They just need an Android phone at home. So aap iske bare mein zara batayega, please.
Ji, Fivzia, you want to start, and then any of the panelists?
I don't like the way it is done, but unfortunately, see, we have the cohort of patients that we have are extremely poor. Neither they do understand about social distancing, nor do they have the facilities of maintaining it. There are 20 people living in 2-bedroom of places which are not even proper bedrooms, sharing a washroom, and then they don't realize. There are people who are infected, told that they are positive, go to mosques and pray there. I mean, so this is one mindset. Other mindsets who do everything properly and so they can be left alone, but then what do you do with these people? I mean, there's no middle way.
Anyone else wanted to add something, panelists?
I can give just a brief thing on our U.S. experience. I think so initially in Illinois, when a few weeks ago when this started, we had very limited testing, and so we did exactly what you're recommending, which is that when we had patients who fit the criteria for COVID and they were otherwise not even moderately sick, those who just had a cough, cold, a little bit of fever were otherwise doing well, we told them to stay at home. And we found that majority of those people, especially the adults, with children tended to stay inside, but a lot of the adults were not following social distancing at all, and they were going out. And this again within the U.S. in a population that is otherwise pretty well educated. But even then, I think the pull of I'll just go to grocery store and wear a mask, but it just wasn't working out. And so now Illinois has we have a lot more testing, and we now have drive-through testing, so people are not having to come into the hospital and exposing other healthcare workers. And so we've limited that, but we are getting a lot more strict about quarantining people who are positive and following up on them, making sure that they actually are quarantined, even in their own house. But it is difficult to do that if you just leave it up to the patients themselves.
Yeah, I can also add my own experience. When I came back from Pakistan on 13th of March, we had a conference there on family practice, and then this started. And I didn't know how our office would be open or not. And second or third day, one of our key staff had this, initial symptoms, cough, sneezing, a little bit of fever. So she texted me and said, what should I do? She went to urgent care, and the urgent care said that no testing. And I said, how come, why can't they test you? Because I'm thinking that if she's tested and she's negative, she can still work and, come to work, but otherwise. So then I called the urgent care provider and I said, why are you not testing her? So he said there's a guideline and this and that. And then I understood it's really the resources. At that time, we didn't have that many kids. And same thing in Pakistan at this point. South Korea had a lot of kids, obviously, so they tested everybody. So if I think the kids, the resources are there, then people should be tested so that the population as a whole know where we stand, how many cases, even if they are mildly symptomatic. But if not, then then you have to do the quarantine, self-quarantine. If you have mild symptoms and you're not getting tested, definitely, that's what we did, and I think it worked. So let me go to Abdul Rahman. You have a question, please ask your question directly to, I think, for Fivzia or Dr. Arif. Abdul Rahman, did you have any? Okay, I don't know if Dr. Herekar is still there. It was a comment, I think, that whether he can screen the patients before they come, distance screening. Like he was, concerned about how to restart his practice. So I think one of the thing is that you can do telehealth, but also if not the whole consult on telehealth, on just on the iPhone or whatever smartphone, you can ask them how are you feeling. If they seem sick or they're a little bit of sick, then tell them not to come for their consultation.
Sorry, my speaker was on mute. So we have policies here that probably may be helpful for Dr. Arif Herekar or somebody like that who may be wanting to protect their staff and their clinic. So we have actually a questionnaire that we have developed in Alberta here in Canada that people can complete before they come in. And so they can send it to you via either email or text messaging. You have to set up that system. So, you will know if there are any symptoms before that, before they arrive. And if they have the symptoms, that you can actually advise them to stay at home, whatever other precautions they need to take. Not every person who has symptoms need to really come to the hospital, because by doing so, they will infect everybody else and spread the germs. So I think if you can connect with them then by phone, if they have some symptoms, you can guide them what to do. So that will be a easy thing to do, in some ways, protecting yourself and yourself and still carrying on the practice.
Okay, great.
Shahid,
Go ahead.
I need to say something. I think considering the reality on the ground in Pakistan, considering all the things which we know, how in close quarters people live and their mindset, I think if we develop the healthcare providers who are there in Pakistan, if develop a strategy in terms of trying to educate our common people, is when the school was closed, people were, crowding into the malls, in the restaurant, and other places. And now still is going to be difficult. So, increasing the number of ventilators, you could not increase to treat the whole population. Increasing the workforce, you could not do that. If things are going to go out of the hand, if the people are not going to understand the gravity, and each individual on their own personal level, on their own family level, if they're not going to listen to the reality, nobody can do anything to save the 5% of the population. That's the mortality. With the good hand, if somebody is on the ICU and in shock in the ARDS, their mortality is 2.53%. So the only difference is 2.5% to 2%. That's what the reality is. So people has to think through this and then make a decision. I think this is important for public education. I think healthcare workers, our educators, our teachers, they should come to the airways. They should come to teach people rather than our politician and our government leaders.
Yeah, that's right. Now let me go to Sohail Akhtar, one of our attendees, to please introduce yourself and then ask the question. Sohail, you're unmuted. Please unmute yourself.
Right. Thank you. My name is Sohail Akhtar. I work in Indus as well. I'm a pulmonologist. My question is a little different. In Karachi and in some other cities, we are facing a problem of any patient that has to be admitted to a private hospital or a government hospital, for that matter, for other reasons. You may have a bad diabetes, he may have had to have surgery and whatever. He's asked to get a negative COVID test before admission. Now, I just wondered its wisdom, because patients are actually being neglected and not being admitted at times for even emergencies, and they have to run from one hospital to the other. And the other is a more pertinent question is for panelists, for participants in other parts of the world. What is their policy in the country? Thank you.
Gee, any of the panelists or?
For emergent admissions, for emergencies, this is Dr. Kabani. For emergencies, there is nobody is being refused care and asked for a COVID test before. Besides, the turnaround time of the COVID test has not been rapid enough to even make that feasible. So that certainly is not something that we are seeing over here. What has been done, which I think Indus has done to some extent also, is that they have COVID units where the patients are getting admitted. A section of the ER has been sectioned off where suspected COVID patients after screening are taken and they're checked. And if there is a real suspicion, then they go to those COVID units instead of the general floor. But that is because of the rules and regulations, and the obligations of the hospitals not to deny care to anybody. That is prevalent in this country all over. So that is not an issue that we are seeing. I think what I have seen though is, and what I've come across lately is that because of the utilization of resources, including intensive care resources for COVID patients, patients that are coming in with non-COVID related problems are being sometimes managed by people that are not as experienced in critical care, because all the critical care doctors are in the other units, and that has happened in several hospitals here as well. So we are facing that type of a problem. And I do feel that the care of the non-COVID patients in the healthcare system is getting affected. Plus, televisits and all are fine, but there are some patients who even here are not able to come for televisits, not comfortable with it, not. So those patients, I'm sure in the community out there, are also not getting the care they need. So there is a big impact.
Gee, anyone else? I would, if Imjad Hussain is still there, I think he raised the hand and I got to him late. He lowered it. Do you still have question, Imjad?
Hello?
Gigi, go ahead, Imjad.
Yeah, I wanted to make some comments.
Yeah, sure, go ahead.
And that was in terms of, I think, our policies regarding management of COVID patient, and especially in terms of Pakistan, I was saying that we are kind of penalizing patients. Like we are making it harder for people to even report, and especially when we have no testing. I think what we should be doing is a model of zero surveys. We should be doing active testing in terms of the disease burden. We should be doing antibody testing. I think it must be cheaper and a lot easier. And especially our healthcare provider, they have been exposed. That's what my beliefs are. And even reports are coming from Pakistan, like Indus Hospital and other places. A lot of healthcare worker force has already been exposed. So what we should be doing is rather check for the immune status of our healthcare provider, so that if some people have already developed antibodies, then we can like use them as a frontline worker, more as a frontline worker, as a even frontline legions, because they are kind of already immunes. And so far we know that people who have developed antibodies, they are going to keep their antibodies for a certain period of month. It has been seen from previous studies in Frontier and other about Mars, and the same kind of SARS-like coronaviruses. So even Germany, they are like looking for some sort of exit strategies. They're thinking maybe people who have gotten exposed, they should be given an immune certificates, and they can be more useful. That's what I wanted to comment, and probably a few more.
Thank you. Nuzat Asahi has a question. Please, Nuzat, go ahead, unmute yourself.
Hi, this is Nuzat Ashai. I'm a nephrologist at Cleveland Clinic. I first wanted to really congratulate APNA for arranging for this forum. It's a wonderful resource for information where there's a glut of information from all over, but it is very good to listen to our own colleagues, their experiences. I just wanted to say that in the United States, what is being done in terms of protecting kind of the right of patients who are non-COVID and are critically ill, in some of the hospitals here in Cleveland, at least, there has been cross-training, and patients and the providers or the physicians have been trained in a very short time on actually critical care. I'm actually surprised and shocked when we got emails about that we will be pulled if there is shortage of people dealing with this. So there has been some cross-training. Many of the surgeons who do not have elective surgeries now scheduled, they are actually part of the occupational health line, and they are fielding questions about COVID-19. They are, so there's a lot of delegation sort of responsibilities being placed. In terms of, I actually wanted to address the last comment about antibodies and using those physicians or health for Somebody's microphone. Okay, can you guys hear me?
Yes, please speak a little louder. Please unmute yourself if there's a background noise. We are almost coming to the end of the session.
Yeah, I just wanted to say that we really don't know that presence of antibodies does confer clinical immunity. And that question is being raised right now. But I totally agree that if there is availability of such a test, that would be instrumental in bringing back the workforce, to the forefront.
Okay, great. I think with that, we already have really gone over. It was so interesting as usual. And so unless some panelists have a pressing last comment or question, I would like to close. And thank you for the panelists from Pakistan, Professor Amir Ghafoor and others, and our Indus team as usual, and our speaker, most of all, Fivzia. That was a great presentation, and really we appreciate you coming whenever. I know you guys are busy there taking care of patients really at the forefront, but it really makes us feel very appreciated when people from Pakistan attend or become panelists or speak. Please let us know about other speakers from Pakistan who we can invite and reach out to, and also how to increase our attendance. And with that, we'll close the. Fivzia, you have last word, or?
No, I just wanted to thank you for having me here.
Okay, thank you very much. With that, we conclude today's session. Until tomorrow, please take care of yourself. Stay safe. Thank you. Assalamu alaikum.